Hello. I have the pleasure to present the next case for the live case session. It's about 67-year-old male with high-grade stable angina with typical risk factors. He had sinus node dysfunction and we implanted a pacemaker 4 months ago. He has known coronary artery disease, 2023. PCI of the left anterior descending artery was performed, and he presented at our clinic with instant occlusion of the LAD. And we did a procedure. We did the CTO, implanted another stent, and a month later, PCI of the right was performed. He has normal echo with preserved ejection fractions, with no wall motion disorders, with no severe valve lesion. We typically perform dobutamine stress echo, which induces ischemia in 7 anterior segments. This is the angio of the occlusion, and you can see on the right side the procedure, the end result of the procedure. It was done in September. And this is the right, very tortuous vessel with one big stent implanted proximally with this good final angiographic result. And this is the anatomy of the left system. As you can appreciate, there is a trifurcation of the left main with one big intermediate branch with osteostenosis of the circ and distal left main stenosis. You can see from the cranial projections the left main. And during the procedure of the CTO opening, we did some IVUS measurements. And for the distal left main, the area was below 6 square millimeter. And for the ostium of the circ, it was around 4 square millimeter. This is the case. And proximal LAD with nice lumen. This is the case, which is open for discussion.
Sorry, but probably I missed this. Do you perform FFR?
No FFR. IVUS.
Just IVUS?
Yes, we have non-invasive assessment, ischemia assessment.
Yes,
it was stress test, stress echo.
Because there is a study now that with the area between 4.5 and 6, there is a recommendation that probably this should be additionally verified with the FFR.
Yes, you're absolutely right.
Maybe we can ask the operators if they already didn't stent it.
Maybe this is the plan for today, to do some functional assessment, but we can discuss that with the operator.
Okay. So, do we have a connection with
Let me check.
GatLab? Ravi, what do you think?
I agree, because this is not a simple left main intervention. So I think the more data you have, the better it is. So they are doing it.
Yes, they are. Obviously, we think in the same way. I see that Dr. Zheleva is preparing to do FFR. So, hello, Eva. You look beautiful. You don't have a microphone, so we have the advantage to speak to you without reflection. Yes, okay. Maybe Dr. Gelev will be dressing now. Did we have some non-invasive proof of ischemia in this for this patient?
Yes,
Nikki?
we have. As I mentioned, we have dobutamine stress echo, which induces ischemia in 7 anterior segments.
7 anterior segments. This is
anterior
before
wall
opening of the LAD or after?
After that.
I'm really skeptical, yes, to be honest, because it is very focal lesion.
In fact, we did the measurements, IVUS measurements, just after the CTO opening in order to know if we have to stand also the left main. But in this complex case, like big branches, big intermediate branch, big circ, we decided to stop and stage the procedure and do some non-invasive assessment. Of course, right now we prepared the core benches, we will do some functional assessment, but this was the plan to open the CTO and to check if any other procedure is necessary.
We're waiting for the instructions for the editor, yes.
Hello, George.
Hello, hello.
Nice to
Gabriel,
see you
we
in a case starting with functional assessment, a little bit atypical for you.
Yes, 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 yes. So we are waiting. Dr. Gelef is here to direct the proceedings. So, Dr. Gelef, where is Eva?
Sometimes to do
Okay.
complete functional assessment is a little bit harder than to cross the collateral.
I have to say yes, and
I'm
I
not
have the
joking. It looks.
No. I'm also commenting in a serious way. I had the opportunity through my latest appointments to be exposed more to physiology, and it is a field that is not easy. You have to understand well. You have to have the knowledge in depth in order to be able to assess. You were presented with a case,
Yes.
correct? So let's see. I'm waiting for Dr. Geleva to come and tell me what
to do.
what already Eva, what you have done for imaging. Just
Also,
before.
we have some
Okay, I will
projections.
write
Yeah.
that. So this is
the LED. This is the stand that was occluded.
yeah.
And
There was
we
an instant
recanalized
occlusion
it,
there. It was recanalized, and the result now is.
Not
As
bad.
I can see, it's excellent, not bad. So let's see, what else did you film? Here we see.
Yeah, this is the left main.
There
It
is,
a
you can
trifurcation.
appreciate the distal left main in this projection. We might do another one.
Next, yeah. Next, that
Yeah,
goes with
yeah,
the,
that's fine, that's fine.
This is
So
the
this
right.
is the right coronary
we
artery.
fixed the proximal severe lesion.
There was a severe lesion also over there. And yeah, that looks also okay.
And this is
And this is
the trifurcation before nitro.
Yeah.
And next,
the spider.
no, because
It's overlapping.
Yeah. Every
I don't know,
projection.
but this is a kind of an. You can appreciate it is an awkward trifurcation.
Sometimes.
The intermediate branch takes so strange. Even I have seen the diagnostic.
Sometimes I personally prefer aeriocranial, very
Yeah.
cranial
We can
reverse
go and do-
spider. Just
Yeah, let's try quite steep areocranial, if we can do that. So it's. If you can tell the patient just to turn his head a little
може
bit.
ли да
from there.
обърнеш главата наляво? Наляво. Тодоре, наляво. Така, хубаво.
Okay, this is a quite steep area, as much as we can get.
But still it...
A little bit
just
of contrast,
with
Eva.
us. No,
No, there is a
No.
much overlapping and...
Contrast?
I don't know. It's
No, it's
not
not
good,
working
no.
here. No, it's not a good one, as far as I can see. Contrast? Maybe this one. Let's try. Film.
No, caudal projection.
Yeah, you can see the ostium a little bit of this intermediate branch over there. So all in all, despite of the imaging, what spider you didn't try at all, huh? Let's see if we can have a last spider, and then all in all, what is regardless, because even the diagnostic angiography is not going to be of any assistance in this case. I think as Dr. Gelef has planned, our intention here is to do physiology of all three vessels, if I am interpreting well the plan that we had. So, Valerie, why don't you present a little bit again your impression from the previous IVUS that it was done? Because I suspect that we're going to go directly to physiology rather than imaging at this stage.
Can you hear me?
Yeah.
Can you hear me, Dobry?
Yes.
So this is a case, interesting one. It was three-vessel disease, CTO of the left of the AOD, and we opened it. And during this procedure, we made a NIVOS on circ and AOD. And it seems that probably you remember
Let's see this.
Nicky
Might be okay.
there. He is going to correct me, but the left main was around 6 square millimeters, around 5.9, I think. We have a good minimum women area in circ and in AOD, but still we ask this patient to come and we make a stress echo, and the stress echo is positive in 7 segments in anterolateral part. And now, so we have to, in our opinion, we have to address this problem with, let's say, a compare and functional assessment with invasive functional assessment with non-invasively, because IVOS is borderline, but of course in these curved vessels we are not sure what is the cross-sectional measurement that we have done. So that's the idea, to start with
Intermediate.
Yeah.
No.
Valerie,
Okay,
Valerie,
let's equalize first.
Somebody mentioned FFR of all three. Why all three? You have a distal left main lesion.
I cannot hear you well.
The question of Ravi is regarding the why to measure all three vessels,
Circumflex.
FFR to all three
Okay, let's
vessels,
equalize
not
here.
just, for
to
example,
flush?
to the LED.
Yeah, flash it.
Yes, we are going to start. If we see probably, but it went into the circ. If we see, because it's important for us to know how is the FFR there. Probably if you went, a good option is to go into, after that, into the AOD, measure it, and I mean measuring if all three measurements are negative.
Okay.
And probably the next thing should be to go into the AOD and make a functional assessment, a full functional assessment. And this is what you can see. This is the Coroventis system, and now we have equalized it. And the question is how to perform or how to induce vasodilation, because if you go for the three vessels, these are 3 papaverine injections, or maybe we can go with the adenosine in the
Maybe if we go to
intermediate
the distal-
into the circ,
we go
more
and
distal-
after
more
that
distally, maybe?
for the left main in order to
Our
do
intention
to assess the
was
microcirculation to do
Because there is
papaverine.
another plug
What do you think about this?
And,
So, Valeria, I would think if it was positive in one, then you have to treat it. But the best thing would be to give IV adenosine, stable state, instead of intracoronary papaver. No.
I don't know where we are.
Valerie.
Should we give some contrast? It's a small
it's a
branch.
small
Valerie,
branch.
Я увеличете звука на...
Excuse me, you should speak to the microphones because we can barely hear you.
Okay, Valerie, may I suggest you something? You know,
Yes.
we have already got a lot of, let's say, literature on non-hyperemic parameters for coronary stenosis severity assessment. And so if you have a Coroventis system, so RFR is available.
Yes.
This is the easiest way to start.
Yes,
because
that is what we are going to do. Robert.
Because in terms of adenosine or hyperemic derived let's say indices, the process of infarction, disorder in contractility can, let's say, influence the final results. So I would rather focus the final decision on non-hyperemic parameters.
You are absolutely right, Robert. But what we are going to do is, and what is our practice when we do, when we start functional assessment, if the non-hyperemic here, RFR, is convincing, it is more than, it is around 1 as it's in the moment, we are going to measure now, we just accept it as
It's normal.
Pull back. It is not. This is the pullback.
Now it's pullback. Just give me a second. Here.
Maybe to start with non-hyperemic, and if they are strongly negative, just to escape
No, that's
the
what
adenosine.
William's saying. If they are quite convincing, as it is in the case, it's 0.99. We're going to do it once more. We accept them, but if there is a
You can make a pullback,
borderline-
and if you have no gradient across the stenosis, that means
No,
that
now we are going to do a
definitely this is about
RFR
stenosis.
pullback. It's again 0.99. And
Exactly.
now we are going to do a pullback from there. So
Okay, Valerie.
we can pull back.
Yep. Okay, there was an intermediate lesion also in the mid segment, but
But still there is no gradient.
there is no gradient at all in the intermediate one. And I am in the guiding, Valerie.
So this is one, but it was
it's
99 and
completely
now
Yeah,
one.
it is one.
so this is very convincing.
Absolutely.
Yeah,
So we are going for the next vessel.
okay.
It's a very useful exercise, George.
I will
The-
let it run into the way of, let's see which vessel is going to be, vessel is going to take. It goes to the LAD, I think, or
The problem with the LAD here is that the
let
wire,
me just go a little bit to the
wire
spider
bias,
so I have a little
which
bit of
could
an
be
idea of
introduced because of this very
where are
tortuous
we going.
vessel.
Maybe the
And
I think this is the LAD.
yes,
He has a strange anatomy, I have to say that. So it's, yeah, this is the stand. So,
exactly, super,
okay. I think it's fair enough to
Yes.
accept that.
absolutely.
It's safer also.
So
So,
around 92,
make equalization.
maybe
here,
some
but
nitro additionally because the wire is irritating the, now it is
I
straightening
can
the
pull back
vessel.
gently and correct
Yes.
that. I think
Maybe
that's-
if we can go a little bit further, just
Yeah, I
to
will.
make a full assessment here, because
Yeah.
we're in the LAD and to assess the microcirculation finally.
Yeah, I
it
will
be
do
a
that,
good option.
Valerie. I think it's...
Just a little bit.
yeah. I
this
think
way.
the vessels are big, so we are just going to advance that a little bit more.
The very curious
Yeah, I think
point
that's enough,
will
huh?
be
Excellent.
Yeah.
So
if FFR is non-significant, how you will explain the non-invasive test result?
of course, we know that these tests sometimes can be very, of course,
Misleading.
very rarely, but sometimes mistake can be done. And don't forget that it was an acute LAD. Probably there should be something in this direction. But anyway, let's see. We assume that this is a gold standard, so we shall see. Nitro.
yeah, just put
Promihne.
some nitro. Yeah. Promihne, да.
Okay, that's interesting.
61?
This is after nitro.
No, no,
after
this
nitro.
is
After the
This is
cold
the
the
flow
nitro
rate.
and the
Nitro.
cold saline.
Yeah. This is a line given. So it's,
This is something. And here is, when you assess your result, always look at the curve, distal curve, because
No,
if
to
the
be-
distal curve has the same,
Yeah.
It's
It is-
comfortable.
the same form like a proximal one,
No, we have to wait.
no matter what is the ratio, the change that the chance that this wrong result is huge.
We are measuring
Just,
the RFR.
Papaverine.
RFR will be positive now, borderline,
0.89.
at least exactly at the both. Okay, but the curves are completely identical
No, but the curves
on
are
form,
good, yeah.
which for me is a little bit
Sorry.
some.
So these rest indexes are only proxies for the. These rest indexes are just proxies for the
Exactly.
for the
This
FFR.
approximation to approximation.
Exactly. So I think in these borderline cases with discrepancy with functional tests and so on, I think I would not hesitate to do hyperemia and then to.
No,
to
it
assess.
is, we are not discussing this. We're going to do hyperemic, we are going to do vasodilation with papaverine. This is 0.90. Still, because we are going to do a functional assessment of the microcirculation. So we are starting, and but before that, we are going to do it before vasodilation. And we are going to the next step. You see, how with this wire we can go and proceed all this.
Just to note that finally last year we published the protocol with
Come, Eva.
lidocaine prevention of
So
VT
we're going to go now for the
before giving,
microcirculation,
papaverine.
Valerie, before papaverine.
Yes, we are going to make,
Assess.
just to explain, we are going to make 3 bolus of 3 milliliters of
to be prepared.
saline. Wait,
Okay.
George, I will tell you.
Yeah, you will tell me when to
We
inject.
are going to measure this, the transition time. Inject now. And you
First
can see
injection.
here, we have this difference, and we have a very good
So just
number.
for the
So we
audience,
are ready
this
for a
is
second.
thermodilution
Inject.
type of measurement of all indices that could be measured. They now
Inject now.
taking
Yes,
the
third one.
baseline condition just to assess not only FFR but also to assess the microcirculation. And the end
It's
result
nice,
will
very
give
Yeah,
Both
very
measures.
consistent. Yes, very
FFR,
71, 69,
CFR,
72.
and IMR.
We don't need more.
No.
We're all
I think
accepted.
that no, one of them was
Ah, okay, one more.
We have one inconsistent
we have
measurement,
the-
so
I inject now.
fast. Okay. We are with you are with the 6 French?
We are 7.
7.
Inject.
So in this case, my advice is to take a 5 milliliter syringe and to repeat all 3.
No, we have done it, and they are
there-
quite good.
No, it's okay. It's 6, 7.
The numbers are
Consistent.
consistent. Okay, so
We're going to-
lidocaine.
So the IMR here is.
No, it's not.
No,
We
no,
have to
we're
do
going
that.
No,
we have to do it
hyperemia.
After
now with
hyperemia,
hyperemia and
you will
then
have
measure
it.
the. So the baselines have an average of 0.7. Okay.
Okay.
It's a little
So this
bit
is the papaverine.
brisk
minutes.
flow.
I was given.
Yeah.
Okay, I give
Yeah.
full of it.
Yeah, full of it. 20 milligrams, 20 миллиграмма papaverine.
So I admit having limited experience with papaverine in the coronary vessels.
Excuse me, Valerie.
So is the effect
Sorry,
more
sorry,
prolonged
sorry,
than with
sorry, there is a lot
adenosine?
of
So you
bubble.
can
2-3 minutes.
2-3
something
minutes.
like that.
So you can easily recognize the steady state that
Yes, you have a steady state after 20-30 seconds. What is written, at least for Bulgarian patients, after 20-30 seconds you have a
Okay.
stable hyperemia,
Papaverine now.
Papaverine,
and you
yeah.
can start
Okay.
your
And
measurements.
9
And
ml.
after
9 milligram.
maybe
9
1.5 minutes you can do pullback.
Yeah.
8.
18 milligrams.
If you want.
18.
So how,
Nine-
the entire
9 milliliters.
9 millimeters. Okay. We're giving now the papaverine.
Okay.
Okay.
Here, no, it's not a problem.
And
the flash.
we give
Flash, yeah.
1 milligram per kilogram
Okay, so-
lidocaine
Okay, and we're going to go
1
now.
minute before applying papaverine, just
Okay.
to prevent ventricular
All right.
tachycardia. And we published this
First injection.
frontiers in cardiovascular disease last year.
Mary, let me know.
Just wait.
Inject.
Okay. Inject.
Second.
Yeah. Wait.
We're making the hyperemic injections now.
Very
And
good
now?
and very consistent numbers.
Third.
And the third one.
Third. Yeah. Perfect.
Yeah, it looks
Perfect.
It's good.
It looks
You-
good.
yeah.
Can you see the screen?
Yes, the CFR is 3.2, the IMR is 16, but the FFR is 77.
0.77.
If I see right
Yes,
from
you
here,
see well.
this is 0.77 FFR with the normal CFR and normal IMR.
Let's do a pullback.
Okay.
Just a second.
Maybe you can do
Let me know over
PPG just for the demonstration and about the
Yeah, you know,
diffuseness of disease to assess.
PPG, no. Okay,
You have this software there.
Yes.
for 15 seconds.
And we have to make the pullback when I told you at least 15 seconds should be
The pullback, the duration.
the duration.
Okay.
Start.
Can we
Okay.
see the laptop?
FFR is positive.
Dr.
It
Guerra?
is
Thank you.
0.77.
3, 4.
So the stress echo was right. The
The interesting point here is that, yes, this is a focal lesion. You can see the step
This is
up.
the
Clear.
We are in the guiding.
Okay, yes. So this is just before the guide. That
Can you
means
see the
that-
PPG curve?
Yes,
Yes,
yes.
It looks like that.
It's good that it is focal,
Yeah, but it's
but
borderline focal.
still borderline.
It's borderline
yeah.
focal, yes.
okay.
Not exactly, because you see, we started from 0.89. I mean, we have exhausted the papaver
Yes.
vasodilation.
Do you
So
want to,
no,
try?
it's not necessary. We
Okay.
have proven and we know where is the
Problem.
finally the problem.
Yes.
And
Should
Now-
we try to go in the intermediate branch, Valerie?
I don't think
No.
You don't think that's necessary
we
because
have,
we have the
left main AOD
yes,
significant.
yes.
And now
Yes,
the
exactly.
visualization
Yes.
of the ostia of the three branches became crucial
Yeah, for the
because to assess the result, let's say if you go to a crossover stenting, I see that if is
I
ready
have the
to
feeling
comment.
it's
Maybe-
excellent. Yes, we will
Can
go
you-
to that one. What
Can
I
you have a
believe,
better spider? I mean, spider with a lot
Yeah,
of
we will go back to
a
that.
lot of LEO.
I will try to do that, but what I
Spider,
see,
a lot of LEO.
yeah, what I see from this projection is that there are, of course, 3 branches, but I think the intermediate branch is more marginal rather than true intermediate. So I do
Maybe.
believe that the crossover stenting
Maybe.
might be not that complex or how we treat. Anyway, I will try to go as much as I can now to a spider position. We will see how we can. I'll try to go even more.
yeah.
Do you know what we need, Eva?
Yeah.
If we can put this patient, this arm of the patient, a little bit back behind his head, or something like.
Може ли да му кажеш да му сложи
From
главата,
a
ръката
didactic
под
point
главата?
of view,
Or
this is a
not the-
very good
yeah,
example
or both of them,
of all
because
the
I saw
elements
that
that
there is a
integrate
little bit
the
of.
FFR.
If we can,
Yes.
we will put the patient
Angiographically,
arm,
the
both
LED
of them.
Да си сложи ръцете под главата.
Probably the simplest possible strategy
Yeah.
is
Take,
to
please
do,
try to put the
do
other one
a
also
crossover
behind his head,
stenting
because
pot
if I go very
on
much
the
into
left
caudal-
main IVUS and then FFR on the intermediate and
Try to put the
circumflex.
left arm
And
also
if
behind
they
his
are
head.
Okay,
This
okay,
is
okay.
possible. Change.
not ready yet.
finish the
dots.
procedure.
Сменете точките.
This is the simplest possible way.
Okay, let me see when the. It's okay, it's okay. Let's see when the arm is coming and if it comes
For the
in.
left main, yes.
What I meant is that angiographically, the lesion
Okay.
at the LAD
I think
seems
it's okay.
irrelevant.
Let's try to make another injection.
However,
here.
the subtended myocardium
Just a
is
little
much
bit.
bigger,
Okay.
and then we have a positive result. While the circumflex angiographically it seems
We have a lot
quite
of saline.
ugly,
That's okay.
but the
Flash it
subtended
again,
myocardium
just,
is
flash.
small, and then we have a
Yes.
negative result.
In
That's,
absolutely negative. It was 99, 1, just.
No,
Despite
Let's
that,
make the film.
no.
on angio, it looks at least 70% this
No,
osteostenosis.
it's not.
At least.
I think that this is a typical trifurcation.
Yeah, it's
And
okay.
this-
It's okay. Valerie,
You are
I think
so-
we will proceed
know.
with the treatment, correct? Okay, let's have a run through. We will take this wire out.
We have it.
3 run-throughs.
So this is,
Не,
I
не
think,
трябва
one
и
of the
два
most
водача.
difficult cases because you cannot see the ostium of the
Do we
side
need to
branch.
do imaging or we have the...
And practically, the only way to assess the effect after
We will do
stenting
that.
is
With
just
what
to
kind
do
of stent we will
again FFR
4.0
on these side
or
branches.
4.5? 4.0.
If we,
Or
5.
even simpler to
Yeah.
do intercoronary ECG, and if there is no ischemia, just leave it alone.
Of course, this is not ideal, Dobrin, but might be we should go to the traditional approach. We have to scan all of the branches for this, or at least circumflex and LAD. I remember that
I
the
think so, because he has
lumen area in the orifice
on
of
the
LAD
screen,
was
and
around
then is
4.
the LED.
A
There's
little
just,
bit
More
above.
than 4.
A little bit, if I remember. Why it's most important? Because after standing over the circumflex artery, the shape of the ostium, circumflex ostium, will let's say change into the oval, and then will be decreased up to 30%. If you remember the Kang's proposals, 3.7 and 65% of plaque burden, that was very strong. That were very strong predictors for compromise for circumflex artery. So might be we should explore at least circumflex artery because of that.
Okay,
After
we have
that,
at least a
after
wire in the
stent.
circumflex. Okay, the challenge will be to wire the intermediate branch. We will see how we will do. We put already the wire in the circumflex. So the strategy here will be to do a crossover, as we discussed.
I think that we
I
can
don't know
make
if
a
we're going to
picture
do
here.
immediately the imaging now, or we're going to use, I don't know if we have the
Or
IVUS
staging
available
protection,
from the
yeah.
previous time. It's not going to be a bad idea, but as Dr. Gelev said, a 4.0 stand will do the job here. And then we can always optimize. Or you want to do an IVUS in advance. Again, the circumflex is the most natural curve there.
But you have IVUS measurements from the previous IVUS. You
Maybe
can
Yeah.
open the
Yeah,
previous
I will.
IVUS and to size your stent from the
Okay.
measurements from previous IVUS. At least
This
for
is
the
the
left main,
intermediate
nothing
now.
changed. I'm absolutely
I
sure.
don't think.
We'll go now to see. There is another branch that is not entirely clear where it is. Let's make a film, Dr. Zeleva.
I think that this is the diagonal branch of LED. We have to something like a diagonal.
So this is not the intermediate, eh?
I'm not sure.
Why don't you try left cranial as a projection?
Yeah, we will see
Yeah.
contrast.
Eleocranial?
A little bit of contrast. I cannot see the. Let me wire the LED
Maybe-
first. Yeah, the cranial one will help us a
I
little
think
bit.
that the caudal,
Maybe caudal spider
Caudals
extremes
were-
more than 90 degrees LEO
Intermediate.
should be below the table.
Just
because
directly cranial 30.
I think that caudal right.
Let's see about the cranial 30 here, as Dr. Gelev says. Epicranial.
Epicranial 45 sometimes.
Contrast a little bit. That might be give us. This is not a bad projection. Let me see.
Yes, but
Let's make a film
This
here.
is
I
not
need-
probably
there are
the
4
best-
branches film.
the
This is
best,
the diagonal.
yes.
So I'm in the direction of the LED.
Yeah.
Okay. Let me see if I can go. The proximal part is the LED. I will wire the LED now, and then we can always. This is the LED. Let's take the third wire now to see what we have. Okay. This is the LED. It's a very big vessel. And Dr. Geleva, let's
Yeah,
put.
I'll
I will
mark
put the
them.
LED
Yeah.
over there, the circumflex. Let's see a little bit what we can wire here now.
This is really a friendly case from Valeri.
Yes, it is. It's a welcome. I think I need a little bit of a bigger curve for the intermediate branch. Let's see how we are going to achieve. But here I can see. Let me see, Valerie, if I can just by any means make any progress there. Because this, we have to go a little bit into the circumflex. I will go. It's, yeah.
This.
No. The curve to the intermediate is much steeper. It's a steeper curve. Contrast?
Yes, this.
You're
That's
there.
it.
Yes.
Yeah. It's pure luck, I can tell you that. Okay, we have the wires.
Okay.
Sometimes it's good to have some luck.
Yeah, it's better to be lucky than good. So, we have to go in this one. Let's put in the intermediate. Ivan, put the torquer. Put the torquer in the intermediate because it's the most important wire. Remove this. Put the torquer in the intermediate. So, Dr. Gelev, what do you think? Crossover, how long and what kind of stand?
Valery, can you take the microphone? Because
The stand was 3.5 up to 4 atmospheres, but the question is first, are we going to overlap two stands? And I think 3.5 can go up to 625.
can you open your previous IVUS and just to measure the reference vessel diameter of the LED and to size your stand?
It's easier for us to do a new IVUS, so...
okay.
Let's do a new IVUS.
If it is
Let's
easier,
repeat a
just-
fresh IVUS for you to...
I have a comment to do. What I see is it seems that the left main is not bigger than the LED, even maybe not bigger than the circle. So maybe he has a diffuse disease in the left main. So you may have to change maybe the diameter. So to choose the diameter, either you measure the calculation of the
Yes.
diameter of the left main from the three branches,
For 3 branches,
or
0.5.
you use an IVUS. I say use an IVUS to see the diameter of the left main. Because it will be important to put a stand able to go up to 5. I don't know how it is.
I hypothesize that probably if, as I see, this is 433, these are at least 10 millimeters summary reference diameters. So 0.56, it is at least maybe 5.5 or 6 millimeter balloon for pot. And even it is possible that it is even more than 6.
Okay, we'll
But
do the IVUS
yes.
now in the LED,
Okay.
which is the most important thing. I think it's okay there, Valeria. Okay, let's... So we're in the stand in the LED just to have a measurement. And we are pulling back now. The result over there is excellent. This was the occluded vessel. So we're going now proximal LED. We're exiting the stand.
This is more than 4 millimeters proximal.
Is there any? I can flash it.
We can have.
Where is the flash for the?
The left main is
IVUS?
huge.
Here. Okay, I will just give you a little bit of flash to clarify the image more.
Sorry.
And there is a calcium nodule there.
We're still in the proximal LED here. Can you see the? You have a good image of the IVUS? I see, Valeria. I see. You can focus on the screen. I can see it. Focus so the audience can see. It's a big LED.
It's more than 4. More than 4.
I think the stand should be in the direction of the.
This is the
We are
proximal
now
LED.
reaching the. This is
distal
the
trifurcation.
ostial LED, and this is the trifurcation, as you can see. And this is the left main. It's a very tight left main, and the left main is big.
It's huge.
We will need a 6O balloon.
At
So
least.
what I would suggest here is that. Okay, we should stop. Yes. Eva, I stop.
Yeah, we
Yeah.
stopped.
Oops, just a second.
Sorry.
So we need to go with a 4.0 stand most probably. And we will need balloons up to 6.0. And we should go all the way to the ostium of the left main.
Yes, and you should take a stand which could be dilated to 6 millimeter diameters.
Добре, като е излязъл, хайде сега.
Maybe,
Промием бързо.
I don't know what, I saw that they
4.5.
Nagomi.
4.5
I
might
think
be the best
4.5.
choice, yes.
You are not obliged to go to very high pressure in proximal LED.
No, we can
And
just...
you use the pressure only for the pot, for a big pot.
Yeah, exactly. This is not a bad projection here, this AP, because we can see the ostium, we can see also the proximal LED. This is the other projection that is not good. We can see the left main problem there, but I think the best projection to do the stenting is this projection here, which is, this projection here is RAO8 caudal 1, so it's AP. And 4.0 or 4.5, Dr. Gelef? 4.0, 24 might be too much, huh?
Yeah, because there is a
24 might
stand
be
on
too
the,
much. We
on
don't
the
want to.
outcome of
Maybe 18 might be better.
Diagonal.
Yeah, 18.
Дай да видя
18
диагоналния,
or
има
20 or
стенд на
something like that.
диагоналния
18
на
would be enough, I believe. What do you
Има,
think?
да. Дай го си.
There is no need to cover ostium, so you have to take a shorter one. 18 would
Yeah,
be,
yeah.
would be
I
enough,
think
I
18
guess.
would be more.
Ето го
18 will
диагоналния
be
имаме
more
с
than enough.
стратове, да.
And as you said, it's not necessary to cover the ostium. I'm not very much convinced that for the left main, if there is no reason that you need to cover, we will go close to that, but we will not really. That's why I like the projection. So this projection is again.
Дай тук да видя остиума на диагоналния.
I think it's
Yeah.
AP. Eva, where do we see over there the exact film?
I can't see also. Let's see.
Somehow
Кажете
I am-
проекциите, че не виждаме зад найлоноса. Имаме, we have a stand over
This
the
other, I believe
ostium
that
of
it
the
is not
diagonal.
necessary
Are
to
we
do a
going to
predilatation. It was
overlap
not
that?
calcified. I think not.
No, this is for this reason.
4018.
What is this stand?
18, okay.
Yeah, I think it's fine. 4018.
4.0,
Okay.
4.018.
Кой ще отваря тук?
Contrast.
Контрасия. Диде, отвори го стента, бе.
This is not exactly the projection that I did.
No, this is the AP cranial.
This one is epicranial.
Okay,
Може ли да кажеш
so-
коя е тази проекция?
Eva, what type of stand you choose now?
Nagomi.
Nagomi.
Is going to be.
No, I'm not happy with this. I want the previous projection, but I cannot see exactly the.
Because we can go
okay,
up to 6
RAO8 caudal
millimeters
1.
with the Nagomi. We can
RAO8.
overexpand the stand. So
RAO8. Okay, and then we have RAO8
Е, caudal
Actually,
1.
and caudal
From the
1.
modern stands, there now we have a couple of stands which
Okay,
3540 stands which could be
we found the
capable
projection
to be
that we
dilated
want.
up to
Look
6
at
But
the
there are
contrast.
wires and
millimeters,
this will
even
be-
more.
That's okay.
Personally,
It's okay. I'm
I
happy with this
Okay.
projection.
was able to dilate even the
Let's make the
stands
contrast
which
not
are not
too thick.
assigned that could be dilated up to 6, but we do a high pressure, I mean 25, 30 atmospheres and
18, нали
it
18?
stretches. It's another story
That's very good.
how
No
the characteristics of
predilation, no.
stand changed.
I think, Dr. Gelev, this lesion is perfect for a DCB.
DCB,
To make lesion preparation with the cutting the loop.
DCB for this case.
I think this length is good. Contrast? Yeah, maybe a little bit back. Let's make a film, Eva.
Really.
Yeah, I think it's perfect there. What do you think?
George, why don't you check it in some cranial just regarding the
We
ostium
can
of the
check it. Yeah. We
the
will
left
do
main.
that. It's a good-
Only this.
It's a good suggestion.
Just not to hang.
Yeah, it's a good suggestion. It's a good suggestion just to see the
ostium, the very ostium. Just
maybe. No, it's good. It's good. Maybe we should put. Let's make a film there.
yes.
Maybe we push a little bit,
yes.
1 millimeter more distal. You agree?
Yes,
I
absolutely.
think it.
Yeah.
Sometimes the problem gets better defined when you film with the
Okay,
stent,
film.
like in this
Yes,
case.
exactly.
I am happy there, to be honest with
Absolutely.
you. Yeah. Okay, Dr. Jeleva, let's go up. Yes. Yeah. It is a tight. Go 6/8. That's enough. Okay. Down. I think this is a good. I will remove the balloon and then we can see.
Maybe you can repeat this inflation a couple of times just to be sure that the stent is inflated.
Okay.
Maybe in cumulative time up to 30 seconds,
I
something
think
like that.
45 seconds, even if 3 times, it will be-
45
will be
each time or
No,
No,
cumulative.
three times 15 seconds or
Cumulative
something
okay.
like this.
Cumulative
Somehow he
time.
tolerates that very well. He doesn't blink an eye, but blood pressure is good. Okay, 15. That's an indication that the side branches are open. Because the patient is not... let's go one more time, Eva. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 15. Down. Okay, so the patient tolerates these inflations very well. Hemodynamically, he's very stable. Let's be careful also with not to disturb the stent because the stent is certainly not well opposed. We might need with a 5.5 proximally. Let's make sure that we're not losing any wires.
Let's.
Let me just do things here better in the right way. I'll do. Okay. Thank you. There is
Just
a little
for
bit
the audience here
Okay.
to
Let's
obtain
make
the
a
proper
film now just to see what we
stent
have.
expansion, you need some time. And this
Okay.
time is the total time
Let's
while
make a
the
film there.
balloon is inflated inside the stent.
Ready.
So you need at least 30 to 45 seconds just to be sure that
How much contrast do you have? Why don't we make
stent
4/8? It's a very
obtained
big territory.
the
just have a
nominal
He asked to.
diameter which should be obtained according to the
Can we move a little bit the
pressure
screen
which
there?
is applied.
I will
George.
go to the code. Yes.
But there is
First of
a-
all, the information that we have here is that all branches are open.
George, I have a tip for you.
Please.
When you inflate your balloon,
Yes.
you just do a micro puff,
to
a small
see if
puff.
there
You know,
is-
1 cc of contrast,
Okay.
you will know if you are on the wall or not.
But this is for the pot.
Regarding, yes, during
The
pot.
During
adequate
pod, you mean?
For adequate pot.
Yes.
Okay. That's let's do the spider here just to have an idea of. Okay, let's see what effect we had
And
until
you can
now.
inflate the balloon without contrast inside the.
That's excellent. So we will do
Mixture.
that. How do we proceed, Dr. Gelev, with what kind of post-dilatation there?
6.
According to the IVUS, maybe 4 or 5.
The panel thinks 6 millimeter will be okay.
And
5.
5,
or
okay.
4.5.
Bigger. Okay.
What
Yeah, I
size of
think so.
balloon? Valerie?
We're going to take a 4.0 for the distal
5,
part
because
of
we
the
are
stent,
lacking
and 5.0 for the most proximal one, and we're
5.5.
going to
But
do
if we
IVUS.
go high atmospheres, it's going to become 5.5 millimeters as the diameters.
There is no 6 millimeter balloon.
We will see what kind of we're going to achieve here, but
Some peripheral balloon or rhino.
as we said, what is very interesting here is that all branches remain well open. The ostium of the circ,
Nothing changed.
Looks the same.
I have to
It's
see a
the
little
same.
bit,
It
a little
looks
bit
the
of a small
same.
puff. Yeah, we can see it's
Nothing changed.
unchanged.
If we can remove.
Nothing changed.
Maybe an
We're going to do the
interesting-
post-dilatations, and afterwards, of course, we will, a little bit of contrast, Eva. That's also a very good projection. Let's make that film.
For the circumflex.
We're
yes.
coming back to the point of the circumflex ostium. You can see it clearly here.
It's pretty fine.
We can do
the same.
FFR afterwards here. And we will decide. Let's optimize the stand. This is not a bad projection. Let's have the 4.0 first. Yes.
Or, you can always IVIS into the
Let's
LAD
take the 4.012. What do you think, Dr. Gelev?
and then look at the circ.
Yeah.
George, you can IVIS the LAD and look at the circ ostium to see if the stent strut is
after
across
that,
the
yeah.
ostium.
Excuse me, I didn't understand. Why was the LAD to see what?
But you can see the circ. You can see the circ ostium
Yeah.
when you pull back.
Yeah, we will access the circ
Yeah.
again. We will access the circ again, and I think we can do both imaging and physiology at the ostium of the circ. But as we said before, it was quite revealing the conversations that we had before. I mean, the two lectures that were given also by Dr. Stankovic, and the last one were very elusive on what we expect at the ostium of the circumflex. Let's do the post-dilatations, 4.0 for the distal part of the stand and 5.0 for the proximal, and we will take it from there.
I think always a hot topic for the bifurcation fanatics is
I don't
which
see
kind
the
of
same. Do we
balloon
have
you
the
use
boost
for
here?
pot.
Yeah, over here.
Non-compliant or
I'll go a little
semi-compliant.
bit cranial.
Because
I
here we
believe. I
have
think cranial I will see.
divided opinions.
Let's see what we have here. The stand might be visible better here. We will see.
So
Yeah,
if you use non-compliant,
a little bit more distant.
we will be able
That's
to
okay, good.
produce
Go higher pressures there,
0.25 millimeter over expansion. If you use a semi-compliant balloon, you can go to up
6,
to 1
18,
millimeter.
14.
So make a difference. So to give the diameter, you have to use a semi-compliant balloon.
This is
The stent is deployed by 3 atmospheres, so it's not a
distal
matter.
optimization at the moment.
Yeah, with 4.0.
Okay, 16, 18.
4.0.
Let's go. Yeah.
Yeah.
This 4.0, we're going to go high pressures now for the middle part.
4.0.
16, 18, 20. Let's go higher pressures there. It's okay.
Okay, 20.
Okay, down,
So,
safe.
Which kind
And
of
let's
balloon
take
you
the
use
5.0.
for the pot?
This is 4.0, 12, and C.
Non-compliant?
Guys, give some
Yeah.
contrast after during
Okay, let's inflate again, 6, 8,
Okay.
10, and we'll give some, I'll do.
and give some
6, 8,
contrast
10.
during the balloon inflation.
Yeah, okay.
Okay. 14, 16.
That's enough.
Okay, and puff, and you see
Yeah, there is
it
a
goes
minor-
into the
Yeah.
into no. This is rim intermediate.
No, it has some perfusion distally. We can see the contrast. Let's take the 5.0 balloon. For the proximal, we'll go high pressures there. Okay.
I'm really afraid that 5.0 will be too small for this left.
We will
main.
see, we will see.
We have an option for 6.
Excellent, super. Maybe you can save some time if you go directly with 6 for pot.
Let's dilate. We will do the 5.0. What is important is that the pressures are well maintained, the ECG is stable.
Guys, unfortunately we are a little bit delayed. Maybe
We will not be much late here. We will do an IVIS for you, and then we will do an FFR at the ostium of the circumflex. We can do it offline and update you. if there is
exactly. So let's see the
I have a
proximal.
question to the panel. If everything is fine and FFR is fine, how do you think, should we do kissing bones, tracing at this situation, or we can leave it?
Well, classically, I mean, for non-left main bifurcations, we would answer without hesitation, you don't need to do it. But for
This
the
is a
left main, is still a topic of discussion.
It's good
I
to
would do
go
it.
16.
Because Goran just mentioned is that this is, we can continue without,
16.
after the pot, if everything is fine.
Down. I will make one dilatation also with contracts, but 5-0 will be okay over there, I believe. Let me just, can I collimate a little bit, Eva?
Yeah?
Collimate a little bit around the left main. We
This
see
is
the stand better.
a regular indeflator. It is not high pressure one.
No, regular.
It's 30 atmospheres.
I think that the stand, we can go 1 millimeter more proximal. Okay, go 16. I think there is the right place for the ostium.
Yes, and now after
16.
achieving 16, you can
There is
and
nothing
see.
there. No.
No, there is a no. It goes behind. It's in
Think so?
store 4. Yes, I'm absolutely sure.
Maybe a
Okay.
little
The
bit
contrast is
more. If
going
we
behind the balloon. Absolutely.
Okay, go 16.
Just make
So-
a movie and you will see clearly.
Okay, I'll
Okay.
make a movie with Phil.
And now inject the contrast.
Where?
There's
It's
nothing
still,
moving.
yes, it's visible.
Still
The
three
intermediate
electrocytes,
branch is
maybe.
visible.
Actually,
Okay, so let's see what we have here.
Drish.
one of the challenges of the pot is that the position of the marker with respect to the balloon geometry is very variable. I mean, you read Finette's paper, they describe very precisely
Let's do an IBUS.
which brand, where the position of the marker is, but the reality is that it changes a lot. So even then you focus a lot, you amplify to position it correctly, the variability is so high that the chances that you do it too proximally or too distally are not negligible.
They even, it exists a balloon from China with a very short nose. So it's completely changing the position of the balloon close to the carena.
And actually, I liked from the Balton technology, they had the bottle balloon. And this was ideal for this because the marker at the transition between one diameter and the other was far more precise that you can obtain with a regular balloon. And then for pot, dot, it was ideal, but I think it
By
has-
the way, I'm co-author of the patent of the bottle balloon.
Okay. I should go a little bit more distally, huh? I didn't want to go to inside the distal stand.
But it is
You
not
are-
available
You are
anymore.
in the distal.
I am in the distal, so what we see there is the distal stand. Not to confuse you, I'll come a little bit back.
It worked well, by the
I
way.
think we're okay now.
Okay, start.
So let's start the pullback. So let's flash a little bit. If I will do the flashing. Just keep the IBUS there. I will be flashing here. That's good. So this is the proximal LED. We didn't reach as yet the standard segment, correct? There is the stand.
It looks well opposed. You see?
Here are
wires.
Here is the left main. It's okay, don't pull.
No, I just.
We need the bigger balloon proximally.
Yes, we commented the same, maybe 5.5
Enough, stop.
or even 6, but not at very high pressure.
Yeah, very good. Let's do a little bit manual, just to see the details of this. Stop it a little bit, Eva.
Yeah,
Just,
it stopped.
okay. I will do
Please
manual
just-
pullback. Okay. You see Valeria? Okay.
Maybe
Okay.
you have to take a look also for the coaxiality between the guiding and the IVUS, just to be
Okay, this is a
sure.
manual pullback. This is the distal edge of the stand. I'll go a little bit more deep inside now. Here,
There is no stand.
this is a stand, but it's not well opposed there, I think, Valerie. Even the distal one. let's say a little bit more proximal. Here is better, but I think still we need, maybe we need 5-0 in the distal stand, and we need,
Here is hanging at the
just a second,
close
I have
to
to
the
pull the
ostium
guiding a
of
little
the
bit back.
yeah.
I have to put the guiding a little bit back.
Oh,
We're going to dilate with 6-0 over there. We didn't
Yes.
extend into,
Yeah.
definitely.
yeah, we are in the left main. We didn't extend that.
I doubt that we are going to extend it.
So,
Compose it well.
George,
Yeah,
Valery,
yeah.
But,
my
um,
suggestion
Yes.
is to continue with the program now, and we will come
Okay,
back to you,
Yeah,
let's say, after
that's good.
first presentation.
Excellent. We
We
will do
will go back, that will be after 15 minutes
Okay,
approximately.
Did I-
Okay, so we can continue on during the faculty dinner, and now I would like to switch to the CAT lab just to see the result from the live case, and then we will continue with the presentation of Dr. Mileva. Can we switch? Okay. Hello, guys. Valery, do we have a connection with the CAT lab? Did somebody is aware that we are connected with them?
Hi.
Okay. So, Eva, can you present
So the
the...
images, it's not
Ah.
necessary to show the curves.
Yes. Hello, George, again.
Hello again.
So, we left you at the moment after pulse dilation with the 5-0 balloon.
Yes.
And you decided to pulse dilate with 5.5 or 6.
I will show you. So what we did is that we took a 6.0 balloon. I'm sorry, this is too. This is the stand placement. There was a rewinding. Then we did the 4-0 high pressure in the distal part, if you remember.
Yeah.
This was the 5-0 in the proximal part.
Yes. Yes.
We did the IBUS afterwards
Yes.
that showed that there
Yes.
was no. So we took an 6-0 balloon. We did an IBUS here, if you remember.
Okay.
And this is again. Where is this? There it is, the 6-0
Yes,
balloon.
this is the 6 balloon.
Yeah, this is the 6-0 balloon. We went a little bit deeper, just before the trifurcation.
Okay.
And this is the 6-0 dilatation. This was at 7 atmospheres distally, and we went a little bit higher proximally. And I think this size is good.
Yes.
Afterwards, we did an IBUS here, and it showed that there was a very good expansion.
And achieved the minimal stented area of the left main 22.6 and the osteo LED 10.6.
10.6.
Yeah.
And the left main 22.
And the left
Congratulations
main
for this result.
Thank you.
22. And we proceed.
Because we wanted to avoid any
Yes, I see that you...
mistrust. This is crossing with a run-through, and we made the measurements with the assist microcatheter. I was not able to wire with the Abbott wire. And the FFR, Dr. Geleb, was?
The DPR
DPA.
The DPR was 1.
The same.
Yeah,
As
absolutely
I
the same. Yeah.
Yeah,
suppose
exactly.
that it will be.
And
Yeah.
then
And we measure also the LAD. And again, the DPR was again 0.99 this time. as you
Excellent,
see.
and congratulations.
And these are the final images just to show you. This is the injection in the left main here. That's one. You see the ostium of the circumflex. This takes quite perpendicular from the left main. And this is the final one here.
Yes,
That's the outcome.
This ostium of circumflex is very appetite for people who want to go into deep trouble.
Absolutely, yes. We have to agree,
Okay,
but
so-
the numbers are not lying.
Thank
Thank
you
you very
thank
much.
you, thank you
Thank
guys.
you. Thank you.